So to simply say a symptom is because of diabetes and then move on with it, it's really disappointing when that happens, when it's not diabetes. And it happens so often. And then people live with symptoms that sometimes are simply, quote unquote, a nuisance, but sometimes can be life threatening if left unchecked and not diagnosed. And that's what is most, I can't think of a nice word, frustrating, disheartening to me when I'm working with people who have been struggling for a while and have misdiagnoses.
Welcome to Think Like a Pancreas, the podcast, where our goal is to keep you informed, inspired, and a little entertained on all things diabetes. The information contained in this program is based on the experience and opinions of the Integrated Diabetes Services clinical team. Please discuss any changes to your treatment plan with your personal healthcare provider before implementing.
Thank you for joining us today. My name is Tavia Vital. I'm a registered nurse and certified diabetes care and education specialist. And I'm joined today by
Alicia Downs, RN, MSN, CDCES, BCADM. I'm one of the RNs here at Integrated Diabetes as well.
We are talking today with you about when it's not your diabetes. And Alicia and I were inspired by this topic because it is something that comes up repeatedly in an ongoing fashion. And we wish it wouldn't, not because we don't love figuring out the medical mysteries, but we wish that people with diabetes who have other presenting symptoms could have more medical professionals listen to their symptoms and not just go, it's your diabetes, and move on. Alicia, What are some of the most common things that you think that you've experienced that people come into their visits with and they claim it's their diabetes because they think it or the doctor told them it was?
As the nurses at IDS, when patients have other medical stuff going on, they're our specialty. I mean, these are my people. I love these people. These are the people that get me excited. But it's really gotten to the point where when I have patients who, and a lot of times our first initial assessment or early days working together, neuropathy, peripheral neuropathy, one of the more common diabetes-related complications, I would say probably 8 out of 10 times I have someone who is reporting peripheral neuropathy, especially if they've had pretty good diabetes management. It's not neuropathy when I get into their symptoms.
Or at least when diabetes caused neuropathy, right? The neuropathy is a different background cause.
Well, background cause or just not neuropathy.
Yeah, there's that too.
At all. Another one is anything that's another endocrine thing.
For sure.
Once you get one endocrine thing, your whole endocrine system is then probably compromised in some way.
Or potentially. It's just waiting for something to happen to trigger it, potentially.
Right.
Depending on your genetic makeup.
Yeah. Well, and it's also all a very delicate set of checks and balances. So if your insulin regulation is off, it's not just your blood sugar that's off. It's also potentially reproductive hormones. It's also potentially adrenal hormones. It's also potentially stress hormones. It's also potentially brain function. I mean, the axis, it's not a 2-part axis. It is so many axes that it really is a sphere.
Right. I think of the endocrine system, it's not like coming to a 4-way stop where everybody gets a signal, red light, you stop, green light, you go, and it's very clear. It's more like almost a cartoon style where they have all of these different lanes coming together. There are above ground, flying vehicles coming in. There's the subway. There are all of these on ramps and off ramps, and there's not one lane. There's 8 lanes, and there are 3 different highways. That's more like the endocrine system in my mind. They communicate out like a network.
Yeah, it's like downtown Mumbai.
Yeah, there you go.
At 5 p.m. on a Friday.
There we go.
In 2050.
Yeah.
So there's flying cars and people and tuk-tuks and a guy on a bicycle.
Say a symptom is because of diabetes and then move on with it. It's really disappointing when that happens, when it's not diabetes. And it happens so often. And then people live with symptoms that sometimes are simply, quote unquote, a nuisance, but sometimes can be life threatening if left unchecked and not diagnosed. And that's what is most, I can't think of a nice word, frustrating, disheartening to me when I'm
Well,
working with people who have been struggling for a while and have misdiagnoses.
it can be as simple as the provider doesn't have the time, inclination, and bandwidth, financial resourcing, et cetera, to seek the true cause. So they say diabetes, so they have a code to put in the computer so that the patient can get whatever level of care is available for what they've got going on.
Mm-hmm.
But for the patient, that means they're taking psychological and emotional blame for something that they didn't actually have a part in causing at all. And the message is, if you manage your blood sugar better, the situation will not get worse or potentially get better.
Right.
And that's also not true. You can get your A1C to a 5.5 and keep it there for the rest of your life. And the issue keeps getting worse because it was never diabetes related to begin with. There was actually a study, I believe it was last year, possibly the year before, that came out that they did post-mortem biopsies on people with renal failure.
Mm-hmm.
And the patients that were diagnosed with diabetes related kidney disease, when they did post-mortem biopsies of the kidneys, 3/4 of those were not diabetes related.
Man,
So,
it's not
A,
1 out of 50.
right, it's not even 50-50, 3/4.
Oh,
So, A, those people were living thinking, I did this to myself, right? Because that's the message. It's that
right,
you should be able to control this.
right.
And so you did this to yourself, right? It's not true. A, because it was never diabetes related to begin with. And B, because you can't control your physiology, but separate thing, but also because you were misdiagnosed. There was something else causing the problem the whole time. And if focus had shifted from diabetes to that thing,
There may have been a
there
treatment
could
plan.
have been a treatment that
Yeah.
was just never pursued.
Yeah.
And in renal disease, whether or not that would have changed the quality of life, the long-term prognosis,
It would have
maybe
mattered
not.
when
But
the
it could have
diagnosis
changed,
occurred. Right.
right? It could have changed the person,
Yeah.
definitely, and
There,
their life and their thinking.
Isha, I think that is really important just to put this back out front and center is it's not a particular person's fault or we can't just say, well, if the doctors would do their jobs. No, it's a system problem because
Yeah.
a lot of our physicians are very intelligent, highly trained, very motivated, very caring, and they want to help people find whatever's wrong with their organism and get them on the right treatment plans. They really want that. They're set up in a system that does not support that type of level of inquisitiveness or innovation. They need to get people through in a set amount of time or they get in trouble. They get written up. They don't make their quotas for the day. People get pissed off in the waiting rooms. I mean, there's just so many things. Management comes at them. So they, and like you said, they're all short staffed. There's so much paperwork coming out of everybody's eyeballs. The system is not set up to try to be a detective when symptoms are not flat out. Like if somebody turns orange, we have a clue about what might be going wrong. Can't miss it, right? But a lot of these disorders, there's not a color change, there's not a swelling of a limb or something. It is what is considered vague symptoms. They don't feel vague to the person, right? If you are having chronic pain or if you're having restless leg syndrome or if you're having extreme fatigue, that's not vague to you, but it is not specific to a certain disease that it points to. And a lot of symptoms can be fatigue, anxiety, high blood sugars, stress, lack of sleep, right? Those really can be the root of those symptoms. But if you don't rule out the other causes, that's the missing piece.
It's our whole system is set so backwards. We don't have a system that is wellness and restorative in nature. So let's just say I'm a doctor and I have a patient and I think what I know is their kidneys aren't working right. Okay, that's what I know. What their symptoms tell me, kidneys aren't working right. I can't say I'm writing these labs for diagnosis of renal issues.
Right.
I have to put a diagnosis code. So
Right.
before I even do any screenings, I have to diagnose you.
And if
So
you
you've
know
got
Medicare,
diabetes.
they can't do rule out codes. They can't order
Right.
things to
You can't rule it
things out.
out. You can't screen for, you can't.
No.
I literally have to
Pull it
say,
through.
well, you've got diabetes and I want your insurance to pay for this. So I have to say diabetes related kidney failure. And I put that on there and it goes through. The minute it's processed, you are now diagnosed with diabetes related kidney failure. So
And then
now
if you
as your
go see
primary
another
care provider,
specialist, yeah.
right. Yeah.
It's
So now
there.
I send you to the specialist and the specialist pulls up your record and goes, well, you have diabetes related kidney failure. Says so right here. I need look no further. Now I'm going to treat you. Here's your treatment based on these labs that says your kidneys are failing. And this says you have diabetes related kidney failure. Here's your treatment. What's the treatment for? Diabetes related kidney.
Right. It's
Oh
awful.
my gosh. The whole
awful system.
the whole diagnosis, the whole system is set up on a supposition that we put in place just
For
to get
billing
the
purposes.
system going.
Yeah. Just to be able to
It's-
move through the day and make
It's insane. That is the equivalent of someone coming in with a gunshot wound, and I put diagnosis of like severe blood loss, and we
Right.
just run with that. Like that's your diagnosis. We're
And
just
it's
going to run with
not
that.
completely wrong, right? But it's
Right.
missing something
It is
important.
technically right, but it is also not actually addressing the problem here.
Correct.
So
It is a
about-
massive systemic problem. It's not that doctors are stupid and don't care or are lazy. It's that they're overworked, undersourced, and they're just trying to work a system that doesn't work. But we also have to be aware of the system that we're given. And that is a system where diabetes just becomes a line item too much. One important thing is look at the diagnosis on your medical records. When you get that note from your appointment, read it. If there's something on there that looks not right, that looks sketchy, that is just plain wrong, address it.
Correct.
Talk to the medical assistant at the office and say, this is an incorrect diagnosis. It needs to be removed or changed. And please go back in the record to the first time it was there and have
Yes.
it removed or changed. You might have to go through medical records to have that done.
Yep.
It's worth it because that could pop up later and really
Yes.
be a problem.
And you'll be fighting the incorrect diagnosis every time you see anybody into the future if you don't get the original one out.
Another thing is to be aware of the diagnoses that are likely to come up by watching things like this podcast. Another one that comes up so often we talked about is diabetes related neuropathy.
Yes.
I cannot tell you how many times patients come to me on our assessment. Do you have any of these symptoms? And then have you been diagnosed with any of these diabetes related complications? And they say, yes, I have peripheral neuropathy. And I immediately ask them, your peripheral neuropathy, can you describe it to me? And they say, well, it's in my hands, more in my right hand than my left hand.
Right.
And it's really bad. It's mostly at night or just when I wake up in the morning or after I've been working all day or when I've been driving. Timeout. Or it's in my feet, but only during.
It's in my
Timeout.
feet, in my middle toe, right under here. It feels like
only
I'm
the
wearing a
pad
sock
of my
on my middle
foot.
toe. Like, okay, yeah, that is a neuropathy. You're right. But it is not diabetes caused neuropathy. That is it's a different cause and it has a treatment plan. Same with the hand numbness, especially worse in one hand than the other and the symptoms you described. That's not diabetes neuropathy.
And neuropathy, the word neuropathy, reverse it in Latin, apathy, death. Not enough oxygen getting to the nerve means it's dead. Nerves take years, decades to revive, if ever. Something that is truly dead is dead. Neuropathy is largely irreversible, and the treatment is palliative. It is just to numb the pain so it doesn't hurt so much. So
Right.
that is an end street. That is a dead end. Once you get that diagnosis, there is no cure. There is very little treatment. And so where are we going?
Go for
There
it.
are forms of neuropathy with other causes that have treatments. There is also nerve impingement.
Thank you.
The most common injury in America because it is so caused by having sedentary lifestyles, poor skeletal alignment, carpal tunnel syndrome. Oh my gosh, so common. Literally, stretching and physical therapy can completely reverse this
It's caught early enough. Yeah. Yeah.
Like, this is completely reversible, completely treatable with no medication, no terrible side effects, no disability for the vast majority of patients. But because you've been tracked into diabetic peripheral neuropathy,
It's going down the path.
they're given gabapentin and a dead end.
There are actually tests that can be done where they test out the nerve function and they look to see if there are scans that can be done. There are nerve function tests that can be done, and you can get that diagnosis more clarified. You can find out if it's carpal tunnel or if it's from the types of shoes that you wear when you're on your feet all the time, or from cycling, or from all kinds of other things. And if the other tests do not say firmly, quote unquote, diabetic neuropathy, then you have a different group of people that you're going to be working with. Physical therapists, occupational therapists, maybe surgery, depending, right? But it's a totally different plan other than, ooh, that sucks for you. Here's some gabapentin.
And this is one where once you've got that diabetic related peripheral neuropathy, your access to occupational therapy, physical therapy, active release therapy, and chiropractics might be cut off because none of those are effective for diabetic peripheral neuropathy. So you don't want that diagnosis on your record if you don't need it. I had a patient who was 22, had only had diabetes for like 4 years.
Any of you listening right now, you can't tell, but I just rolled my eyes like in a grandiose manner right now. Okay, carry on.
22 years old, had only had diabetes for maybe 4 or 5 years. And yeah, at 22, there were probably a couple of years in there where she was probably a hot mess. Who wasn't in their teens and early 20s?
Right. I don't know.
But even if if she had 2 years of an A1C of like 12, that's not enough glycemic instability to cause nerve death. But she was having tingling in her hands. And so her doctor gave her a diagnosis of diabetes-related peripheral neuropathy, completely ignoring the fact that she was also a concert cellist.
This hurts.
You think maybe someone who's putting their fingers under tension for, I don't know, 8 hours a day might have other reasons for her fingers to go numb? Doc, could she get a diagnosis of cellist-related tinglies? It drives me absolutely crazy.
But something else that doesn't just dismiss it and make it go away, that actually gets a treatment plan in place and further evaluation and treatment. That's the deal.
She was in such a deep anxiety and depression.
Oh, yeah.
Over the fact that she had in such a short time devastated her health, possibly ended her music career that was just beginning because of the blatant disregard of her diabetes nature. Whoa. No, you were a hot mess in your 20s. Join the club. It's called humanity.
Right.
We were all a hot mess in our 20s.
Right.
And no, you had
need
a
another
doctor
opinion.
who had maybe a bad day and just ticked a box and moved on. And maybe they were trying to do, sometimes doctors have this idea of doing kind of a scared straight on your diabetes. And they say, those tingly fingers, you better get that A1C in check, young lady. Yeah. And they think, 2 birds with 1 stone. Her fingers will get better and her A1C will get better. But that's not medical ethics. That's not okay.
No, agreed.
If you're diagnosed with neuropathy shouldn't be positional. So if you change position and it gets better, that's probably not neuropathy. It shouldn't be linked to certain times of day. Right. Neuropathy is blood flow doesn't change with time of day, and it shouldn't come and go. It shouldn't be like Tuesday it's really bad. Tuesday is fine. Yeah. Neuropathy is neuropathy. So if it's not acting like it's dead, it's probably not. And so
it needs further workup for sure. Another common cause of neuropathy that I see people coming in with symptoms of is from low levels of either iron or vitamin B12. Yeah. So in the general population, low levels of iron are relatively common. You think of it in little kids, but you don't think of it in adults, but especially in adults who might be low carbing it and not getting fortified with iron cereals and breads. For example, their iron intake might be decreasing and they're omitting red meats. They're trying to live a more plant-based diet, but they aren't getting enough of the plants that have enough iron supplementation naturally in there. It's really, really common. And there are other medical issues that lead to low iron levels that can be missed if you simply say, I think I have burning and pain or my legs move a lot when I'm trying to sleep at night. And they'll say, you've had diabetes 10 years, so it's neuropathy for diabetes. And they miss it. So if you haven't had your blood levels checked for iron, you hadn't had a complete blood count done lately, if you haven't had a vitamin B12 test done in the last year, you should get that all checked out because there are common causes, some common to the population in general, some rare. Let's talk about rare, Alicia, like low vitamin B12 caused by our friend pernicious anemia. That is rare in the general population, but not so rare in people with type 1 diabetes.
Vitamin B deficiency is a lot more common in people, especially with type 1 diabetes. Celiac disease is also more common in type 1 diabetes, and people with gut issues have higher rates of B vitamin deficiency. We don't absorb them, we don't process them, we don't retain them. There are also secondary autoimmune issues that inhibit B vitamin processing, especially subclinical pernicious anemia. So you might not have pernicious anemia so severe that you are landing in the hospital because your hemoglobin levels are severely low, so you're not oxygenating, so you're getting cyanotic, your lips are turning blue, you're passing out, or your muscle wasting in these really severe levels, but subclinical levels to the point that you're just not well.
You're fatigued. You feel that a diagnosis of malaise pops onto your chart because you just report feeling unwell.
Low-level depression. Maybe you've been on an antidepressant for a few years and it's just not working. If you're for females, maybe you're just not menstruating regularly or kind of you never really did. All symptoms of subclinical anemia that you can go on an iron supplement, but you're probably just going to get constipation and a stomach ache if your B vitamin levels are not sufficient. If you have diabetes, and especially if you have celiac, you're not eating as many of those B vitamin fortified cereals, especially breakfast cereals. There are these gaps that we just kind of stumble into quite often.
And I'm glad that we have our extremely detailed initial intake form because it covers a very long list, very inclusive, I don't want to say long, very inclusive list of symptoms that could be diabetes related, right?
Yeah.
But could be other things that are also commonly diagnosed, more commonly diagnosed with type 1 diabetes, or even for those who we work with who have type 2 diabetes. For example, low vitamin B12 is more common for people who have been on metformin for many years. It's another common that's actually in the guidelines now for providers who prescribe metformin to keep an eye on B12 levels for people who take metformin for a long period of time. But so a lot of these symptoms that are on our intake form, if it isn't a clear cut and dry case, it doesn't sound like the textbook, I'm asking more questions because something we talk a lot about is when someone has a missed diagnosis, not a misdiagnosis necessarily, but a missed diagnosis, it can impact diabetes management. So I think Addison's is one of the ones that I pick up on because the symptoms are specific enough and they're not diabetes symptoms. It gets missed a lot though, because one of the symptoms could be severe hypoglycemia in the nighttime, which that can be caused by insulin, right? And so if we have, once we've fine-tuned settings and the person I'm working with has a stellar understanding of how insulin works, how their nighttime food digestion typically works, how exercise impacts their insulin needs overnight, and then they're getting these random 20 glucose, 40 glucose, 2.0 millimole glucoses at 2 a.m. And it's not from alcohol, from running a marathon, from, It's not from some logical cause. That raises a big red flag in my mind. Or if I see them and then their mom pops on or their kids pop on and they're different colors and not because of interracial marriages, but maybe they have darker skin tone than the rest of their family. And I'll say, are you out in the sun a lot? No, I'm never in the sun. Okay, let's talk a little bit more about this, right? Or I have stomach aches all the time, or I have headaches all the time, or I'm fatigued all the time. Let's talk about some of these symptoms a little bit more. And have you ever had an 8 a.m. test to see what your cortisol levels are at 8 a.m.? No? Okay, ask for it because it's either normal or it's not. And then we'll know more. I see it a lot. It's rare in the general population, but about 1%, it might even be 3%, depending on what study, of people with type 1 diabetes also have Addison's. So while it might be 0.005% in the general population, it's more common in people with type 1 and it gets missed for too long for too many people.
And what we're seeing a lot, and there's a very strange thing that happens in the medical community, is we get these, when we get labs done, there are what are called reference ranges and then diagnostic ranges. We're going to make something up. We're going to have a chemical in our blood called good enough. And the reference range for good enough is between 8 and 10.
Perfect.
And if you're below 8, you're low in good enough. And if you're above 10, you're high in good enough.
Right.
But if you're between 8 and 10, that's normal. And so we don't treat that.
Then you're good enough.
And you're good enough, right?
Move on.
And that's all your doctor's looking for is this is good enough. But studies find that being high and good enough, even the high end of normal, is common in people with diabetes and vastly increases their risks for severe diabetes complications, cardiovascular risks, other diseases, and so on and so on. So in that population, we have a subclass called not quite good enough. And if you're between 9 and 10, you really should have some advanced testing and consider treatment. But you go to your general doctor and your doctor doesn't even know about not quite good enough.
Right.
Or there is a debate in the medical community as to whether not quite good enough is a legitimate disease or just people trying to use medicine to write off their lifestyle issues, which is crazy. Why are we judging people instead of just treating the issue that we have data on? But more of a problem, there's no data code in the payment system to get treatment for not quite good enough paid for. So your doctor won't diagnose you with it because they have to say that you have not good enough when the So again, we're into this system trap. So you as a patient are going and saying, I have all the symptoms of not good enough. And your doctor's saying, but you're good enough. And you're saying, but I'm not good enough. I don't feel good enough. And they're saying, well, go away until your labs are not good enough. And so you have to wait until
it's bad.
Rather than being not good enough, you have to be really, really bad to get treatment because not good enough plus diabetes equals.
Think Like a Pancreas, the podcast, is brought to you by Integrated Diabetes Services, where experience meets expertise, passion meets compassion, and diabetes care is personal because we live it too. Our team of clinicians, all living with type 1 diabetes, understands the challenges firsthand. We're here to help no matter where you are in the world. From glucose management to self-care strategies, the latest tech, sports and exercise, weight loss, type 1 pregnancy, and emotional well-being, we've got you covered. We offer consultations in English and Spanish via phone, video chat, email, and text. Want to learn more? Visit integrateddiabetes.com or email info@integrateddiabetes.com to schedule a consultation.
You know what's interesting about this conversation is if you go work with a rheumatologist, if you have a rheumatological symptom or issue, they deal in that realm of it's sort of normal, but it's on the spectrum, right? And they look for other labs and they look for other symptoms and they look for other tests until they find it and can name it and put a treatment plan, even if some of the main labs are good enough, because they know that, for example, rheumatoid arthritis, the symptoms can start presenting up to 10 or 15 years before rheumatoid arthritis diagnostic values become apparent. So you could make someone suffer through joint changes that can become debilitating for a good 10 years before prescribing medications that can slow down that joint demolition that would go on otherwise if it's untreated. Or you could take what science has shown, understand all of the different lab parameters and measurements that can be done, and start treating the person and their whole body earlier if you don't miss it. If you don't just slap a diagnosis on it and move on and tell people gain more weight, lose more weight, exercise more, sleep more, the standard.
Control your blood sugar. Your blood sugar.
And the thing is you and I have been down this road in our own personal journey plenty of times. And so speaking from our experience from our clients, but also from our own personal journey, the number of doctor's appointments and the number of different physicians you meet with, some who do not appreciate well-educated people who ask questions or bring science into the office with them, the number of times I've been dismissed or condescended to. At one point in time, I was very, very thin, not because I was on a weight loss craze or I was exercising like a fiend. I had a digestive issue that was caused by an undiagnosed autoimmune disease. And I was told things like I had an eating disorder, that I was too anxious, that I must be depressed, that one wanted me to go see the neuropsychologist because it might be somatic. And it could have been, maybe. I mean, at that point in my journey, I was like, well, heck, maybe it's just something I've invented. Crap. But if it is, I'll get treated for it. And the neuropsychologist read my medical history, called me on the phone ahead of the appointment 2 days ahead, asked me a few questions and said, I'm really sorry, but you don't need this appointment. You have a medical disease. I want you to go see these other providers and get these workups done. And I could have wasted an entire day driving to this faraway place, spending more money, having and all because it was in my mind, but it wasn't. There was a diagnosis to be had, and it just wasn't. In some cases, it wasn't taken seriously. It was my diabetes. It's because I'm female. It's because I'm working and I have kids. There were so many things thrown at me, and all very possible, right? Maybe it is that. Then you start to self-doubt, and that puts the brakes on anything useful. It's not until somebody listens and then gets you back on the right path that you can find out if you have a diagnosis or you don't, potentially. And when you have a diagnosis, you don't celebrate like, yeah, I have another thing wrong with me. Great, my body's doing something it's not supposed to be doing again. But instead, you know that the symptoms that you had were different than you had 5 years ago, 3 years ago. And it's not something that you've put upon yourself. It's not because you didn't take care of your diabetes well enough. It's none of those things. You're not doing something to yourself. If you are, great, get diagnosed for that and get the right mental health therapy so that you can get out of that trap. But if there's actually something that can be tested by a blood test or a biopsy, it was a lip biopsy that got me that one. No one wanted to do it because I didn't have the Sjogren's antibodies in the test. And I saw a rheumatologist and she was like, but let's just do all the tests. Go get your eyes tested for what level of dryness and erosion there is and inflammation. Go see an ENT and have them do a biopsy of your lip gland. Both tests came up positive for Sjogren's. And there it was. And that was like 3 years of suffering. I got told to eat more. I got told that that eating disorder about killed me. I about lost my marbles because I was like, I am eating more than I've ever eaten in my entire life. And it's not coming back out up top. It's like, where is the nutrient? Where's it going? I don't have an eating disorder. I can't possibly eat more. It was awful to go through. And I hear it all the time from our clients.
I would say if you have a medical issue, if you are a middle-aged, affluent, Caucasian male of Western European descent with no other significant medical history, and you go to a doctor with a chronic issue, you will get full battery of assessments and direct diagnosis and treatment. The more of those adjectives that you cross off the list, the less likely you are to get assessed because the adjective that you cross off the list will be blamed for what you're coming in for.
Correct.
So if you have other diagnoses, that diagnosis will get blamed for the symptoms you're coming in for. When you're suddenly a preteen female with type 1 diabetes who's a person of color, good luck. Because now everything you come up with is absolutely about a lack of education, your genetic background, and hormones. And it's also not taken seriously. And that is called implicit bias. And it is something that we know that our world is full of, but our medical world is literally designed with it in place. There are whole medical those reference ranges have been designed, skewed for gender, skewed for age, skewed for race, skewed in some cases to take region and socioeconomic class into account. And so we have to come in knowing where we fall in the biases of the system that we're walking into so that we can say, look, I get it. I get where in the boxes I land, but I really am asking to think outside the boxes. And it's really hard because, like you said, we're coming in. I know where in the boxes I land because I study the boxes for a living. I'm a boxologist. And
If there's a
lot of
research
times
study, I
patients-
probably read it, and I probably potentially may have reached out to some of the researchers myself.
writers of it. Yeah. I've
Yeah,
talked to
the
Dr.
summaries.
So-and-so from Tokyo. And
Right.
a lot of times patients will say, well, you know these things. You have all these letters behind your names, so it's easier for you. Honestly, no. Because sometimes when you come in and you say, this is what I know, people get defensive and they say, well, you're trying to say that I don't know.
Correct.
So coming in and saying, hey, I really respect what you know and what you do and that you're here to help. I want to help team us. Can we consider this? Is this worth considering in your professional opinion? And then let them sit with it for a little while. And I tell my doctors that exactly that. Can I share with you this thing that I found and get back to me on it? Send it to them through the portal. Give it to an appointment and then don't ask them to address it with you. Let them sit with it because very often when they sit with it, their defenses are going to come down and they're going to realize that they have learned something.
And they may do some potential reading on their own,
Yeah.
asking on their own, and be better
And
informed.
if they stonewall, always remember your medical professionals work for you, not the other way around. Resources are thin. I mean, finding an endocrinologist is a nightmare. Going to a new one, oh, great, I'm going to have to wait 8 months to get in. Yeah, but if you stay with the one you've got, you're never getting a correct diagnosis, period. You know, sometimes if you're looking at something that's a rare disease, I have just recently gotten a correct diagnosis for Cushing's disease that has taken 4 years to get and has probably been affecting my life for the past 15. Like you said, the diagnosis has been both a big relief because I can go, I'm not a fragile person. It's not my circumstances. It's not my psychology. It's not my lack of coping skills. There is a legitimate biological piece pushing that no matter how hard I push back, I'm never going to roll this stone up a hill. That feels good, but at the same time, it also feels really bad to know that I was asking all the questions. I was doing all the things right. I was reading all the studies. I had all the data. I was in the know for 3 solid years and was still on not a wild goose chase. It felt like a wild goose chase. It was just a real hard goose to hunt. I actually had to get so motivated and so dogged that I had to reverse engineer it. I had to figure out what I was pretty darn sure I had, go to the manufacturer of the medication to treat it, ask them what doctors in my state had prescribed that medication.
Ooh, smart.
And go to those doctors.
That's really smart.
And
okay. Hot tip.
Hot tip. Hot tip. And I'm so fortunate that I'm resourced enough to be able to do that because not everyone is. I mean, if you live in Texas and there are 2 doctors in the state that treat Cushing's disease, that's going to be a drive to Odessa for you.
I would have to travel.
Right. But it was when it's that or nothing, you do sometimes get to the point where you do what it's going to take because the fact of Cushing's disease is you get treated or you're probably going to have a heart attack in the next 10 years. And that's not an option for me. So I had to go. You also have to often, unfortunately, know really specifically what to ask.
Correct.
So, for example,
that's the hard part. So if you went in and you said, okay, if I look back over time, this was my norm. And I noticed over the last 1 to 3 years, whatever the time span is, I'm a lot more fatigued. I can't exercise as long as I used to because I just don't have the stamina to do it. I get headaches a lot. I have stomach aches a lot. Whatever the symptoms are, right? Those are going to be called vague symptoms. And they could be anything, really, right? And so you have to learn about what do you think that disease, if you have no idea, start there. Go to your PCP, ask them these questions, see what they come up with, get some testing done. And then if anything comes out in the not quite good enough ranges, take that and then explore that further. And then talk to your family.
Not quite good enough ranges are really important here too. And if you have more than one thing that ends up at either end. So I've got this one thing that's kind of at the high end of this. This other thing is kind of at the low end of this. That's
might be a
called potential correlation. Let's put those both together and see, is there anything that has those two things? If those two things go out of range in that direction, is there anything there that has symptoms like what I'm dealing with? And then ask that question.
A little statement, a little kind of disclaimer. One, if you are feeling fine, please skip this podcast and move on. Do not start digging through your medical records to see if anything is out of order. Please don't, because then if you Google it, you will have at least 8 things wrong.
Oh, but don't Dr. Google anything.
No, but don't worry, because anything you put in will tell you stress, anxiety, or diabetes. So if you're trying to like come up with something, don't worry, diabetes is always on the list.
And Dr. Google only has 3 now. There are 3 diagnoses for everything in Dr. Google. You're fine, it's cancer or COVID. I always tell patients, like, you can have one lab come out like grossly out of whack and be fine. Like we've all had a blood sugar of like 500.
That doesn't mean I'm having a heart attack or something. It just was.
It's as long as it's not 500 over and over and over and over and over. Like if every time you get your blood sugar checked, it's 500. Okay, now there's a problem. Your BUN, which is a measure of how well your body is clearing waste, or your kidneys are clearing waste, it can be off one time.
Yeah,
that's okay. You might have
just
been dehydrated that
elevated
day, or
glucose earlier or something.
But if it's off twice in a row, talk to your doctor. Or if it's in range, but consistently getting lower or higher, now we've got a trend. So check with your doc, but also asking specifics. So say you've taken your symptoms, you've taken your not quite good enough, and you're getting a lead, and you're thinking, I'm starting to get a good idea of what's going on here. For example, if you say to your doctor, I think it has to do with my cortisol level, high or low, and you say, can we check my cortisol? Yeah, your doctor will go, all right, and they'll check a fasting cortisol. Guess what? You go to the lab, they draw some blood, they check your cortisol. That number is clinically irrelevant because it is so non-specific, because your cortisol level changes like your blood sugar level. It changes based on
it's
mood.
blatantly wildly off, right?
Right.
It's
like
wildly off or wildly high, then clearly there's more of a problem. But if it's in that, like it's in the normal range, but it's kind of this way or that way, it doesn't tell the whole story.
And if it's wildly off, like your plumber could diagnose you, because you would be like, you'd need an ambulance. It'd be rarely that. But you could be quite ill, but that fasting cortisol be within normal range. It's a very specific test that actually has to be 3 separate tests done at a very specific time in a very specific way. And then to diagnose the disease has to be a whole battery of it. And so if you don't know that and your doctor doesn't know that, because now we've gotten into the world of rare disease.
Right.
We've really stumbled into a space where now you're getting the test done and your doctor's saying you're fine based on data that doesn't actually mean anything. And so now you're losing a lot more time. Your symptoms are getting worse. And again, now you're slipping into space where maybe you're getting out, issues from that disease that may or may not be reversible now. So it's time you want to get as specific as you can. Consult other specialists. I mean, that is why it's a big part of what we do here at IDS. One of my favorite things is when we clinically meet together and get all of our brains together and we go, hey guys, I've got a weird thing.
Yeah.
And when there's a weird thing around here, that's weird, because we kind of do weird for a living. So when there's something that I can't figure out, and I'm like, Tavia, can you figure this out? And Tavia's like, I'm not sure. We kind of come and we throw everything at it. And inevitably somebody will be like, do they drink coffee at 4 a.m? And I'm like, I didn't think to ask if the 8-year-old was waking up and drinking coffee at 4 a.m. Okay, just off the wall things, because we think
we've
so
come
far
across them.
Because rare is not rare for us. And we work with patients from all around the globe, of all ages, of all cultures, of all socioeconomic levels. So it's just how we have to think. Which brings another point is I always tell patients 2 things to ask their doctors. One is ask your doctors to adjust their idea of the word rare. I'm sitting in front of my doctor with type 1 diabetes. I am rare.
Already.
I
Your
have a
genetics
rare
are lined up
disease.
for it.
Yeah, 1% of the population has what I have right now. And they're trying to tell me, well,
It
it's
can't be
not
this
likely that.
because
Right.
that's still rare.
Would you like to know how many rare diseases I have right now? I'm up to 6.
So try that line again, but maybe let's reframe.
Yes,
I think really the most important things that we're putting out there today for you guys is to know that if you are struggling with symptoms that you know in your heart of hearts, there is a diagnosis to be found and you've been dismissed, or you've recently been diagnosed with, for example, diabetic neuropathy, we really encourage you the first time you come in with symptoms, the second time, the 10th time, if it gets blamed on your diabetes, unless your A1C currently is above 9%, and it has been, and you're not doing anything actively to manage your glucoses and get them back into safer, healthier ranges, or you have a 20-year history of 9% and higher A1Cs, right? Okay, fine. But otherwise, you're newly diagnosed with diabetes and your medical history shows you didn't have secretly undiagnosed diabetes for 20 years, right? It's probably not the diabetes and you need a further workup. You really do. And it's not wrong to ask. Anytime you have more questions, I like to ask, what's the clinical rationale for not testing? What would make me, when I get these results back, when should I call you if something is abnormal? What are we expecting with these tests? And that way, when you get the test done, if something is abnormal, if the doctor was already looking for it, you don't have to feel like you need to panic. That's what they're expecting. Or if it's expected to be normal and it's not, then you know it's okay to call the doctor and say, okay, I got these labs. What's the next step? But don't let it go and don't let it get blamed on your diabetes unless you can honestly say for X number of years, more than 5 years, I have had really high blood sugars and have not been caring for my health in general. It's probably not your diabetes that's causing these other symptoms. Very unlikely.
We have to take accountability for ourselves.
For sure.
You know, if I've been driving consistently over the speed limit and my speedometer is broken and I get pulled over, I do not get to argue about whether or not I get a ticket. I just get to assume that the officer is correct. But when I am talking to my doctor, I also get to say, with all respect, can we have a conversation about this issue that we would have if I did not have diabetes?
Yep.
Because while I recognize that I am a person with diabetes and that is a piece of my medical world, I am also a human being subject to the full range of maladies that the entire rest of the human population experiences. Can we discuss if it is one of those and just ask them to open their mind to that and to educate you on what that picture could be as well?
Agree. All right. Well, thank you guys all for joining us today. We've had, as always, Alicia and I have lots to talk about.
Let us know if there are other things that you guys have experienced, if there are things that you want information on, if you want us to revisit the topic deeper, farther, wider, let us know.
I think a good one that we could talk about sometime are the most commonly diagnosed other rare diseases that come along with type 1 diabetes.
If you're struggling,
reach out.
You're our
We're
people.
here.
Meet the nurses of IDS. You're our people, and we love helping to dig into those issues and help people find clarity. It's our passion.
Absolutely. Thanks for joining us.
Thanks for tuning in to Think Like a Pancreas, the podcast. If you enjoyed today's episode, don't forget to like, follow, or subscribe on your favorite podcast app. On behalf of Think Like a Pancreas, the podcast, I'm Gary Shiner, wishing you a fantastic week ahead. And don't forget to think like a pancreas.